Thanks for joining, everybody. We're going to give folks just another minute to log in before we get started. All right, we'll go ahead and get started here, knowing a few more folks will join in the next few minutes, and that this webinar will be recorded for distribution and viewing after the fact. But thank you for joining today's Virginia Clinicians for Climate Action webinar series. We've been, I believe this is our 12th since COVID began, and we all adapted and went online for these educational opportunities. All participants today are in listen-only mode and will remain so throughout the presentation. We ask that you submit questions throughout the presentation as they occur to you. You can submit those questions using the Q&A box that should be in your Zoom menu. And today we'll have a presentation from Dr. DeNicola and then have about 10 to 15 minutes for question and answer at the very end. And we will wrap up promptly at 1 p.m. today. So with that, I will turn it over to VCCA's chair, Dr. Samantha Adut.
Well, thank you all very much for joining us today. Our presenter today, Dr. Nate DeNicola, has a very impressive resume, but I think perhaps one of his greatest achievements is getting myself and a group of pediatricians onto Twitter. He was at a American Academy of Pediatrics Council on Environmental Health meeting several years ago, and he walked all of us through hashtagging and adding, all of us looking very befuddled. And he made us all into Tweediatricians, as we are now called. So we owe him a debt of gratitude, pediatricians do. So Dr. DeNicola is a board-certified obstetrician and gynecologist at Johns Hopkins Health System in Washington, D.C. He is the American College of Obstetricians and Gynecologists environmental health expert and liaison to the American Academy of Pediatrics Executive Council on Environmental Health. He represents ACOG on medical collaborations, including the Medical Society Consortium on Climate and Health and Project Tender, and he is the ACOG International Liaison to the International Federation of Gynecology and Obstetrics and the World Health Organization Pollution-Free Generation Initiative. Dr. DeNicola has published peer-reviewed articles on environmental exposures on reproductive health and is an international speaker on this topic. Most recently, he was senior author on a systematic review published in JAMA in June of 2020, entitled Association of Air Pollution and Heat with Preterm Birth, Low Birth Weight, and Stillbirth in the United States. He completed the Robert Wood Johnson Clinical Scholars Program at the University of Pennsylvania, completed his residency training in OBGYN at Tulane, and his medical school training at the University of California in Irvine. And it's my pleasure to pass the microphone to Dr. DeNicola.
Thank you so much, Dr. Adut. I think I'm going to shorten my intro from now on to be just, I am colleagues with Samantha Adut, because that's all that really needs to be said. It's been an absolute pleasure to have been nominated to this position as a liaison between the American College of Obstetricians and Gynecologists, ACOG, and AAP, where Samantha and I have been working together for several years now. And in a way, that's what we're going to be talking about today, is this connection between what happens during the gestational period and the kind of vulnerable windows of fetal development and how that impacts birth outcomes, which have obvious implications for pediatric health. So We will be discussing the systematic review as advertised. I do have my Twitter listed here. Please feel free to comment with that. And these are, just the organizations that are all collaborating together to work on this topic of basically creating a healthier environment for the next generation. The systematic review was done by myself and several co-authors. I want to call special attention to Dr. Bruce Bakar, who was the lead author and has been a strong climate advocate in this space. And we often present this together. And what we start with is that, the spokesperson for climate change for so many years has been this polar bear, kind of stranded here in an iceberg. And it's a capturing image. You might care about polar bears, you might not care that much, but it captures your attention. But it really is kind of remote from human health. A more recent spokesperson is the weatherman, who's being blown away and whisked in all different directions, and somehow can't believe he's reporting yet again on a 500-year storm that seems to happen every other year now. What I'm going to propose at the end is a different spokesperson. Again, just to mention all the medical collaborations that have come around this to kind of reinforce the health message that I think is really at the core of the new spokesperson that I'll present. And it is really worth highlighting that not only is this collaboration between pediatrics and obstetricians and gynecologists a very natural one, it's a crucial one because these are both vulnerable populations who do disproportionately feel the impacts of the climate crisis. And both have made very strong statements. So Dr. Adut is one of the lead authors on the AAP's statements and policy statements and technical reports on this. And as a very welcome kind of ancillary, ACOG has made a statement on this also that does call for things very specific, such as curbing greenhouse gas emissions. But despite some statements from the OB literature that address this, there really was not much that dove into what was happening here and now in the United States population. In the roles that I serve, I would come across these studies that were, say, a few studies on preterm birth, maybe linked to air pollution, and then a few studies on low birth weight, maybe linked to heat. And as they accumulated over time, it really seemed that there might be a bigger picture here to explore. And I was very fortunate to team up with Dr. Bruce Bakar and our other authors, Rupa Basu and Susan Pacheco, also an AAP colleague. And we wanted to do a systematic review to really define what the evidence says about what the climate crisis is doing to US births right now. And so we defined our scope, we thought fairly narrowly, although we still ended up with about 1,800 references. And the scope was this: we wanted US population only. That's not to exclude the importance of global health. It is very important, but we wanted the message that we could talk to US doctors and US patients about. We wanted recent, so we did just a 10-year window. This was back in 2018, so back went to 2008. We decided to look at the outcomes that were the most ubiquitous and most commonly encountered across all populations. So the superstorms, for example, get a lot of attention, but that only applies perhaps to some coastal regions. In certain areas of the country, wildfire season is now a year-long event. And in Northern California, for example, that gets a lot of attention, but that's regional. So we went to look at the things that were really cutting across the entire continent. And those are things like air pollution, PM2.5 in particular, and then heat, which has, again, just ubiquitously been increasing. We also were looking at the health outcomes that had at least the strongest signal on the initial survey. And those are the obstetric outcomes of preterm birth, low birth weight, and stillbirth. So we went through all these exclusion criteria. We found some studies that were excluded based on just not meeting that criteria. Others met criteria, but then the outcome was actually not the exact outcome we were looking at. So for example, there were there were several studies that did involve a conversation about preterm birth, but the main outcome they were looking at was preeclampsia and how that might be influenced by PM2.5. So we excluded that because it wasn't exactly in our search inclusion. In the end, we had 68 studies that were included, and we're going to kind of walk through those. The first topic, exposure, we'll talk about is air pollution. Now, this is where I was born and raised in downtown Los Angeles, and this picture feels very familiar. So when we looked at air pollution related to these outcomes of preterm birth, low birth weight, and stillbirth, we realized pretty quickly that the exposures were too heterogeneous to really pool them and create a meta-analysis and pooled data. But what we could do, and what we did do here, and we think is meaningful, is to tabulate the overall results and show where the significance lies, and report where the risk was if it was significant. And so for the air pollution exposure, there were 24 studies looking at the risk of preterm birth associated with that, and 19 of those 24 found a significant association. Overall, this was about 7.3 million births studied, and the range really did hover around a relatively narrow window. So what's listed there is 2 to 19%, but the majority were right around the kind of 10, 11% increased risk. And all of these, by the way, are adjusted odds ratios. So they're adjusted for things like maternal age, gravity, parity, type of delivery, where possible, using zip codes, socioeconomic status. And then we looked at low birth weight, and we had kind of a similar story. So there were 29 studies, 25 showed a significantly increased risk of low birth weight with air pollution, PM2.5 or ozone exposure. This was the largest category that we identified, 18.5 million births. Again, with the increased risk hovering around 10%. For stillbirth, there were only 5 studies. 4 of those did find a significantly increased risk with 5 million births. So the overall picture here of the tabulation was a strong signal that there was at least an association between this exposure and outcome. And although it's not pooled analysis, the other way of looking at it is that kind of coming at this question from any direction, we found the same association uphold. So whether the PM2.5 was due to air pollution produced by vehicles, whether it was coal power plants, whether it was wildfires, which creates PM2.5, whether it was spatial modeling doing the capturing the data, kind of any way it was approached, the signal rang true. And there are some other ways to look at this. This was not a study included in our paper, but I think it's an important message around preterm birth, which is I often get asked the question during lectures like this, well, isn't preterm birth decreasing overall in the United States? Isn't this, isn't air pollution perhaps even decreasing overall? The point of our paper was not to show an increase or decrease in the rates of preterm birth across the United States. What it was to examine if there was an unidentified environmental contributor to preterm birth. And our systematic review certainly makes that suggestion. In other studies, like another colleague from the AAP Committee on Environmental Health, Dr. Leo Trisande, his paper explores that question. So it's not preterm birth is increasing, but what percentage of preterm birth could be attributed to environmental factors that aren't yet appreciated? And after they controlled for, again, doing a logistic regression for numerous, basically every kind of variable that you would expect to find in an adjustment, they estimated still about 3% of national preterm births could be attributed to PM2.5. And this has obvious health costs, but it has financial cost as well, with $5 billion kind of overall due to kind of altered life, but 760 million would be purely medical expenses. This is another study that was not included in our paper, but is an important ancillary message, because whenever we have an exposure and an outcome, we, want to tease out if it really is linked by anything that might someday become causality, or if it's just random. And one way that you approach that is to then remove the exposure and see if the outcome changed. And so that was the natural experiment that was conducted in Northern California. And over a 10-year period, when the coal power plants were retired, they saw in that region the preterm birth rate drop nearly 25%. Now, this study is often presented with some degree of envy to maternal fetal medicine doctors because there's nothing that an MFM doctor could do to reduce the risk of preterm birth by 25%. The next exposure that we looked at that was, again, ubiquitous and across the entire country was heat. And we can't talk about heat without talking about heat islands. And this is basically a concept that the heat is not evenly distributed in the urban setting. It tends to concentrate in the downtown region. There are various causes for this. Some of it is how the the ground surface absorbs energy, absorbs heat, some is waste energy. But it's also notable because certain communities, typically communities of color, are more likely to live in these downtown heat islands. And so when we look at the data, and this is across all populations, there were far fewer studies for heat. But for the ones that looked at the association between heat and preterm birth, there were 5 studies. 4 found a significant association, just under 1 million births. For low birth weight, there were 3 of 3 studies that all showed a significant association. Of note, many of these studies showed the strongest impact in the week before delivery. So a certain degree increase in temperature in the week before delivery created an increased risk that was elevated to background for either low birth weight or stillbirth. And again, stillbirth, both studies that we identified showed this significant association. And when you look into further exploration of an exposure and an outcome, you would need to have some biological plausibility for this to, again, have some merits or potential for causation. When it comes to mechanisms, presenting heat here, although they're quite similar for air pollution, we do have quite a few animal models that suggest there is biological plausibility behind this. So I won't go into every one of these in detail, but just to show you that there are things that are commonly implicated in lesser symptoms of obstetrics, such as preterm contractions, that it's not hard to make a connection that in an exaggerated way, the preterm contractions could lead to actual preterm labor and preterm birth. So for example, in preterm birth, dehydration via prostaglandin oxytocin release is one of the most common causes for admission to L&D triage. It often is ruled out labor and they're sent home. But again, we're dealing with the extremes of heat, inefficient thermoregulation, and even preterm rupture membranes during the warm season have all been seen in animal models with this. There's also this understood concept of reducing uterine blood flow and altering placental fetal exchange, which has been implicated with fetal growth restriction. And we have similar things linking to stillbirth. The other piece to this, and again, it's kind of like when you remove the exposure, alter the exposure, does the outcome change? When it comes to heat, the answer is yes, it does. So this is a study also done with one of our colleagues, Rupa Basu, looking at how air conditioning can potentially mitigate the health outcomes, or the adverse health outcomes associated with heat. And this study looked at not just obstetrics, but kind of several different conditions in California. And they found that for this kind of aggregate outcome of things like stroke, heat exhaustion, cardiovascular disease, that if the patients owned air conditioning and used air conditioning, and you can see the prevalence here is actually somewhat lower than you might expect. In many populations, only half or so had it. But if they had air conditioning, the income adjusted estimate effect was that it reduced those adverse outcomes by 0.5, about 50%, which is not a small reduction. So that ties into another message of this paper, which was not something we went out looking for. We did not begin our systematic review intending to identify these kind of racial health disparities, but we noticed that there were many of them. And as that message was repeating, we took note of it and tabulated it. And it became actually one of the strongest messages from this paper, is that not only are these exposures, air pollution and heat, significantly associated with increased risks of preterm birth, low birth weight, and stillbirth, but that those impacts are disproportionately felt by communities of color, and this is exacerbating a racial health disparity. So to highlight some examples of studies that showed that, this is a study from PM25 in Los Angeles County. They were looking at full-term singleton births. This is a retrospective cohort study for about a 10-year period. And they saw that the overall risk of term low birth weight would be increased about 2% by the PM2.5 exposure. But the highest impacts were in the areas where they had homes without air conditioning where they were perhaps exposed to more pollution, so it's harder to account for PM2.5. And these were mostly Black communities and also Asian. This is another study looking at ambient temperature and the risk for preterm delivery. This was conducted from 1999 to 2000. And the exposures, again, were in this case heat, controlling for PM2.5, ozone, things that we had looked for in our study. And overall, 8% increased risk in preterm delivery associated with just a 10-degree Fahrenheit increased risk in the average ambient temperature. But again, the greatest associations were for younger mothers, but then Black mothers and Asian mothers. And one final study, just to kind of emphasize the point, this one from northern and central Florida, where they're looking at, in this case, 1,800 stillbirths from 2012 to 2017. And the adjusted odds ratio for all populations was actually not that strong. But when they looked at specific racial health disparities, the odds ratio was much more significant. And so, again, disproportionately felt in certain communities. And one final study to mention, this actually has been published since our paper published last year. And it shows there's likely a synergistic effect between both heat and the air pollution, PM2.5 ozone. And so this looked at both a 5 microgram increase in the third trimester PM2.5 exposure, but also that the risk associated with that PM2.5 increase was made worse if there were high temperatures, particularly in the week before delivery. And this was one of 3 studies that have been published since our systematic review last year, showing the same kind of synergistic effect. So at this point, it's kind of like, well, great. Now what do you do? I mean, if the data is compelling, it's a bit frightening that we have these exposures that seem ubiquitous and outcomes that matter. So the first thing we do as physicians is we talk to our patients about it. We do what we always do. We look for efforts to reduce exposure. We look for efforts for supportive care to mitigate the effects. And I'll go into a little bit of detail about what that counseling can look like. First, just to mention, and this is probably more for my obstetric audiences than others, but I think it's worth calling attention to across the field of medicine, is that the patients do notice this and they are looking at it. And the US fertility rate has been decreasing. We've known that for several years. And among a certain population, mostly people in their 30s, the climate crisis is influencing decisions to build a family and become parents. And between 30 to 40% of respondents said it was a factor in their family planning. This was an article that colleagues and I published in Contemporary OBGYN several years ago. And while this was sort of broad to cover all types of environmental exposures, which include things like Project Tender was referenced in the very beginning of this lecture, which stands for Targeting Environmental Neurodevelopmental Risk. Basically, it's things that during the gestational development as a maternal exposure or during the pediatric period could alter brain development. And a lot of them are in the kind of toxins bucket. So things like phthalates and endocrine disruptors. So a lot of the counseling here is how to avoid those while pregnant. But it does include things like being mindful of air quality indexes and timing of outdoor exercise. And so I've developed this as at least my best practices for when I practice both inpatient and outpatient obstetrics, for things that you can talk to patients about. And other primary care doctors do talk to their patients about these things. So when it comes to air quality, we should be monitoring the air index quality and perhaps guiding patients toward indoor exercise during times of really poor quality. Probably more for the international population, but the type of indoor air quality is massively influenced by wood burning and basically non-gas stoves. So gas stoves are healthier. We kind of, I think, forget sometimes how much of a exposure smoking still is. It in several studies has been shown to be likely still the #1 causer of indoor air pollution for either pregnancy or for children. So smoking cessation takes on an extra environmental dimension. And, you know, I know this is not feasible for all homes, but where possible, the home air filters do make a difference. Much like air conditioning can make a difference for heat, the air filters have made a difference. One of the kind of most fascinating lectures I got to attend in recent years was the ACEEE, which was the American Council for an Energy Efficient Economy. And it was largely a group of architects who were talking about how to approach this from their field. And there are really kind of amazing things that can be done with filtration. Then when it comes to heat, again, monitoring for rapid fluctuations in heat and guiding patients to either not exercise outdoors or change the hydration counseling. I think this is kind of come to the top of mind for myself when I'm practicing inpatient, and I have you know, the woman appear in labor delivery triage, and she's having preterm contractions, and you know, once it's not labor, we can kind of very easily say, well, that was Braxton Hicks, and prepare for her to go home. But during times of especially high heat, there at least is room to counsel more about what you know, what can be done at home to perhaps lower the temperature, if there's not air conditioning, if there's some other way with fans, additional hydration counseling. You know, my colleague often says, kind of, you know, in jest, when you ask where patients come from, we say the waiting room. And yet we know they come from all different types of home and built environments that probably need more directed counseling during certain times of the year. And I would totally understand the kind of pushback to this type of thing, which is, I'm already doing so much. I'm already, you know, so overwhelmed in clinic. How can I do anything more? Well, Dr. Cheryl Holder at Florida International University has a really fascinating TED Talk on how you can structure your entire clinic flow so that a lot of this work actually is not done by the physician. Some of the counseling would be, but a lot of the screening, a lot of the follow-up and supportive measures can be done by other parts of the staff. And she's basically designed how kind of from entering the front door to leaving at checkout, this is really integrated into her practice. One other note to make here, and this is kind of where we take counseling from the clinic to Capitol Hill. You know, when we began our study 2.5 years ago, we couldn't possibly have imagined that it would be publishing on the eve of Juneteenth 2020, when we were at the height of the Black Lives Matter movement, and we were you know, seeing the racial health disparities being brought into a particular focus. Nonetheless, that's when it published on June 19th, 2020. And again, the racial health disparities have become one of the strongest messages. My co-author you know, is quoted here saying, "Black moms matter." And within 11 hours, then presidential candidate Joe Biden was tweeting this same message. And it's something that has very quickly drawn attention by legislation. Because I know this is, you know, an audience that is very engaged in looking at activism. So Representative Lauren Underwood out of Illinois, who herself is a registered nurse, she has really been a champion for this. And she invited us to be part of writing a bill, and we were part of this Black and Brown Maternal Health Environmental Justice Roundtable. And this has, you know, kind of really been informed by a health perspective. So the bill is the Protecting Moms and Babies from Climate Change Act. And it calls for many things that would be instrumental from a kind of infrastructure and social determinants of health standpoint. But so it's all listed here. I'm not going to go over the entire bill right now. We wouldn't have time for any question and answer or really anything else. But I do just kind of leave this here and highlight one section of it, which is prioritizing things, like I mentioned, that are really very, in a sense, simple interventions, but have been shown to have health benefits to mitigate the risks. So things like air conditioning units, appliances, filtration systems, weatherization support, and many other things here that would be infrastructure and systematic changes to help protect the most vulnerable communities. And again, I think probably this audience is as familiar as any, but there's no special training required for physicians to become advocates for their patients. The San Francisco Chronicle article here is from colleagues who were just very concerned, physician colleagues, who were very concerned about the health messages that they saw resonating. And so they wrote a really compelling op-ed that was published there and got a lot of positive attention. And here again, colleague Dr. Picard has been very active in San Diego, where he lives, advancing climate action, where they really do have kind of great access to the local policymakers and decision makers. And there are many collaborations that I could mention. I'm going to call out a few here in particular, but you know, there probably is a whole lecture on just the health collaborations that have emerged around this topic. The Climate Reality Project has been especially beneficial for kind of training trainers. So you are trained in how to give lectures on this topic, and then you can train others pretty quickly. Eco America has their Climate for Health Ambassadors program, and they have frequently been kind of a notice for bringing all these different stakeholders, health and non-health, together in DC every year to have the National Health Summit. The Medical Society Consortium for Climate and Health. This is a really interesting development. So this organization in aggregate, with all the different medical societies that have joined, represents about 500,000 doctors. Somewhere close to half of US physicians are represented, you know, kind of by the organizations that have all joined. And that includes now the AMA. And it's been a very, you know, kind of powerful way to show that it's not just a health message about what I'm talking about here, primarily obstetrics, or what dovetails into pediatrics, but really every dimension of health is affected, whether it's increased duration of allergy season, or whether it's how to time elective surgery based on how the patient will recover during certain times of increased air pollution. And many other, you know, I've been surprised at how many different fields I never imagined would be affected by it have been affected. So I'm going to shift to a slightly different story here, which I hope shows, you know, how long we have a history with environmental exposures and how we have made positive changes in the past. So this is Minamata Bay, Japan, with these blossoms in full bloom. They look gorgeous, the way DC often does around the tidal basin just about a month ago. This is it now, but back in the 1930s and 40s, it looked very different. It was really being overrun with industrial waste spillage. And that industrial waste bioaccumulated and made its way up the food chain into the diet of its residents. And for the pediatric patients was creating things like ataxia and seizures, and in some cases death. And this was really one of our first experiences with an environmental health exposure. It became known as Minamata disease, or essentially mercury poisoning. And this is really, you know, anybody who's ever kind of encountered the field of obstetrics probably is familiar with the story, or at least the message: you don't eat fish, or you don't eat certain fish. And it's fish at the top of the food chain that are highest in heavy metals. But the reason we know to counsel about that is because of this environmental exposure, and then how we changed our counseling to mitigate that risk. Unfortunately, this message continues to resonate, continues to appear in other kind of environmental disasters and exposures. So when the municipal water supply to Flint, Michigan was changed from the Huron River back in 2014, and they had this lead crisis, very quickly the obstetric and neonatal outcomes were identified. So 12% decrease in Flint's general fertility, and nearly 60% increased risk in fetal death after that lead water crisis. In case people ever wonder why we're not doing more in Congress, you know, it is associated with brain function as well, and it's been identified in some pipes. Now, I wanted to mention briefly also, kind of as we close here, what this moment around the COVID-19 pandemic means for environmental stewardship and what it means for scientific leadership. Because this is a picture here of Heaven Temple in Beijing, and on the left side is a very representative picture of most times, and people wearing masks there even before COVID because the air quality was so poor. On the other side is a you know, very beautiful, clear picture after just several months of lack of regular transportation. And these have immediate health implications as far as what kind of PM2.5 exposure we are exposing ourselves to. And I recently got to give this lecture for the International OBGYN group on Earth Day. We had an Earth Day webinar on environmental contributors to preterm birth. And so I have to kind of mention how Earth Day even came about in the first place. This was the picture from the Apollo missions going to the moon, and they turned around and took a picture of Earth. And it was in some ways the first time that we ever saw Earth in this way, with no borders on it, but from a distance. And many have pointed out that after this picture became the cover of Time magazine in 1969, a litany of environmental health legislations went into action. So 1970, Comprehensive Clean Air Act, Earth Day was 1970, EPA founded around that same time, Doctors Without Borders, DDT being banned, the Clean Water Act 1972, unleaded gas 1973. And so it's not to say that this was propelled entirely by that picture, but it was a new perspective, and it did motivate an entire wave of environmental health conservatorship. And a lot of it worked. So I did mention the lead crisis in Flint, which unfortunately continues to be a risk for many communities. But overall, when we changed things like, for example, removing lead from gasoline, blood lead levels did commensurately decrease. And so I am heartened by a series of recent health, either policy statements or decisions that somewhat fall in a similar trajectory. In 2013, ACOG published then really its first committee opinion on this topic under the leadership of Dr. Jeannie Connery and Dr. Linda Giudice. 2 years later, FIGO, the international version of the OBGYN Society, published a similar paper. Of course, AAP has a long history with environmental publications, but the technical report that really spelled out in great detail how this impacts health outcomes. Mentioned Project Tender, the Frank R. Lautenberg TSCA reform to look at kind of high-risk toxic chemicals. I mentioned the consortium. And then even more recently, things like the willingness to kind of get rid of single-use plastics. In fact, single-use was so popular in a time period around 2018 that Merriam-Webster made it their word of the year. And you can debate with them whether hyphenated word is one word or two, but this was Merriam-Webster's identified featured phrase, at least because of all the interest in removing plastic from our oceans. We just had last year the 50th anniversary of Earth Day, and I mentioned the FIGO Earth Day webinar, which was really a kind of important event for at least the OB community to really start to recognize the environmental impact that it's having. And so I'm just going to end here because I think we'll have plenty of time for question and answer, which is as I give these lectures, I'm more and more convinced that this is true, that the best arguments in the world won't necessarily change a person's mind. The only thing that really can do that is a good story. And I hope I've shared some stories that are worth repeating here. Because what we're seeing now is really a different spokesperson for this climate crisis. And if you can see on the slides here, if you look close enough, moms have written over their gravid belly there, it's getting hot in here. And this is the human health risk of the current crisis. And while that is a perhaps scary story, the health benefits that we accrue are not only a very good story, they have the added benefit of being true. We see things like preterm birth reducing when coal power plants are retired. We see things like blood lead levels decreasing when we switched our gas supplies. So we see health benefits that happen relatively quickly, and we have the capacity to make these happen. Our final message, myself and all my collaborators that we end every lecture with, is the mantra that every OBGYN and I'm sure every pediatrician recites is healthy mom, healthy baby. That's the most important goal. Well, healthy mom, healthy baby first requires a healthy environment. So there's my contact information. Thank you so much for listening, and I think we've got some time now for Q&A.
Thank you so much, Dr. DeNicola. That was really fantastic, both on the specific applications to pregnancy and also just on the more general applications for healthcare professionals being active participants in this emerging movement. Before we get to Q&A, I'll just remind everyone that the Q&A box, we've already got at least 3 good questions in the mix. Please continue to populate that, and we'll spend our last 15 minutes or so covering those. But I did want to mention just a couple of advocacy opportunities that we have that we try to include in all of these webinars. One is that VCCA has a Virginia call to action on climate, health, and equity for health professionals to sign to demonstrate to our elected officials in Virginia and at the federal level the importance of the links between all of these topics. It covers several kind of broad-ranging issue areas, encouraging our elected officials to establish stronger climate policies to protect human health. You can check that out on our website at the link provided. We also have our next webinar coming up next month with Dr. Chip Conrad of UNC, who's going to talk about heat illness specifically in the rural Southeast US. He's done a lot of fantastic studies, and we're excited about that upcoming webinar next month, just about the time that we'll all be sweating every time we step outside our front doors. And then lastly, please consider donating to support our continued work at VCCA. We greatly appreciate any support that you're able to provide. And before we turn over to questions, I'll just remind everyone that this webinar is available for CME credit through Innova. You will all receive a follow-up email tomorrow with a link to this information as well. But in case you want to capture it right now, you can use that QR code or click that link for instructions. And with that, we will start the Q&A. Dr. DeNicola, if you can see the Q&A box and indicate what questions you'd like to answer, we'll go ahead and get started there.
Yeah, thank you so much. So I'll begin with what I see as the first one, which is in regards to decreasing fertility, how much is attributable to male factor infertility? Do we have evidence of the effects of heat and air pollution on male fertility? So I can answer that question in two ways, which is sort of a yes and no, which I know is not the best answer all the time. But the male factor fertility is absolutely a factor when it comes to environmental contributors to infertility. The strongest evidence that I have seen is more from the sort of toxic exposure side. So things that are at some level endocrine disruptors. In fact, there's strong, compelling evidence that the endocrine disruptors as an exposure during prenatal periods affect not just ultimately a female fetus and a adult woman's life, but have similarly adverse impacts for the male fetus and for male fertility as an adult. And everything from kind of urogenital anatomy to sperm count. So that is a kind of strong and important factor there. In terms of heat specifically, there's kind of always been an understanding that temperature does matter. It's usually more of a local individual factor, and there are cooling mechanisms involved in people who are trying to treat fertility. As far as air pollution, I can't comment on anything there. I don't have any good studies that I could refer you to that have shown an impact from air pollution on male fertility. So if there's no other comments on that question, I'll go to the next one, which is how do you parse low birth weight that might be attributable to gestational hypertension and preeclampsia from the effects of heat and air pollution, given that the patients are disproportionately impacted by both? Yeah, that's a really important consideration. And like I mentioned, there are some studies looking at gestational hypertension and preeclampsia as the core outcome, and then preterm birth as a secondary outcome, sometimes related to preeclampsia. The way that you account for it is usually through the diagnosis codes that are listed in these kind of large databases that are studied. And numerous factors like that were in the adjusted odds ratios. So it's not just preeclampsia that would be factored into these adjusted odds ratios, but also things like chorioamnionitis, preterm rupture of membranes. So in as much as a logistic regression can account for those, many of the studies did put in maternal conditions like that. But I think it's an important point that there probably is a larger cardiovascular kind of phenomenon happening that we probably haven't spelled out in enough detail. As I don't know if it's a confounder as much as it's maybe a synergistic effect. Okay, so I'll go to the next one then, which is, had mentioned wood stoves harm maternal health, gas ovens are superior. So in Australia, showing increased childhood asthma with indoor gas cooking. So I'm not, thank you for pointing that out about gas, the risks of gas cooking for childhood asthma. I'm not familiar with other studies that show gas with electric stoves having adverse outcomes for pregnancy. The studies that, and I'll include the link to the study, that the main study that I was referencing there, that basically shows that the type of heat and the indoor air pollutants that it creates does have implications for maternal health, and that the wood burning were significantly more hazardous for pregnant women. But I will look into if they're, and so typically, non-wood burning gas are preferred, but that's something that I would look into for pregnancy. Okay, so the next one, not to overwhelm our patients with too many asks at one time. Top 3 actions we recommend to our patients to best protect themselves, their loved ones, their communities. Great question. So I really like this one. The first one, because I want to give things that people actually can do. So when it comes to the heat and the air pollution, I would say that we really should be asking patients, are they ready for the upcoming heat wave? And so the thing the patient could do is they could, sort of be asking themselves, preparing, are they ready for the upcoming heat wave? Because it's not just the ambient temperature being persistently higher than it typically would be. Rapid fluctuations, it's called kind of temperature comfort. So a rapid delta is actually almost as dangerous. And things they can do is, if they have the means, they could more manage their indoor air temperature and indoor air quality with things like air conditioning, with things like filters. And if those aren't available, with the simplest of all interventions in obstetrics, which is just hydration, tons and tons of hydration. Basically the same way that I think you might consider more of a senior population at risk during heat wave, we should be thinking about obstetrics somewhat in the same way, that they need more counseling and protection than simply saying, oh, isn't it hot outside? Try to get some rest. Like, it needs to be more directed. So that'd be number one. Be mindful of the outdoor quality and avoid it basically where possible. Number 2 would be taking it indoors to optimize indoor air quality and temperature, because even before COVID kind of changed all of this, but even pre-COVID, a lot of modeling studies showed that a majority of people spend something around 85% of their time indoors. The whole work that I did with the World Health Organization, it was a little frustrating at first, I've got to be honest, because all the whole focus wanted to be on things that were actionable. So I and others would be saying things like, we need to appeal to United Nations and appeal to all these international organizations to really curb greenhouse emissions. And the response was, yes, that's fine, but our patients can't do that tomorrow. We need things that are actionable right now. So the whole World Health Organization pollution-free generation was toward these actionable indoor things. And with regards to that, I probably won't do it justice to summarize it here, but the kind of city planners and architects and building engineers really can do quite a bit of work in terms of filtration systems to optimize indoor air quality, if that's somewhere that you want to go. I think ultimately what we need are things like what's presented in Representative Underwood's bill that would take the onus off the patient to do this and would build it into HUD planning, would build it into just all of the homes that people will have as a new home. So it kind of takes the onus off the patient. And that comes to the third thing that I would say, which is, ultimately this is a kind of systematic approach, which needs all of our agencies to work for us. And so to factor that in when you're either making decisions about votes or making decisions about who you can talk to in your local community, who are the policymakers, I think the individual actions are important, but there's only so much a mom can do. And at some level, this needs to go higher. So I hope I sort of covered those three. Number one, avoid the outdoors when it's bad, and take extra precautions. Drinking water, number one, high among those. Number two, optimize your indoor. And number three, go door to door, I guess, talking to policymakers. Okay, next question. Any sense of dose exposure needed for heat and rates of preterm birth? Yeah, that's a phenomenal question. We don't have that yet. That's one of the hardest things to answer, is like what temperature creates the risk, or what critical dose of PM2.5 makes the risk. However, you could extrapolate from studies. So the PM2.5 are typically presented in interquartile ranges, and you can identify what number counts as the highest interquartile range, and make some extrapolations for where the risk is highest. With heat, again, there's not a specific tipping point temperature reading, but we were seeing more and more, and this is probably where more studies can shine a better light, about what degree temperature increase in the third trimester was associated with the highest risk of low birth weight and stillbirth. So for example, a 10-degree Fahrenheit increase during the warm season in the third trimester had a much higher association with these adverse outcomes. So you're getting close to a dose effect there. I guess the other thing to mention here on dose exposure is more not so much related to heat, but perhaps related to the air pollution generated by fracking, because there was a study that I didn't mention here, but it was out of Pennsylvania, 1.2 million live births, looking at the risk of low birth weight around a fracking site. And if you were within 1 kilometer, the risk was 25% higher for low birth weight. If you got to 3 kilometers, it was 10% increased risk. And then as you got out past 5 kilometers, risk went back to background. So it's kind of approaching a dose response, but that's not really exact to say like, X PM2.5 creates X risk of preterm birth or low birth weight. Okay, I see another one here about the property insurance companies have climate change on their radar from increased risk of natural disasters. Are the health insurance companies taking climate change into account? I am more than happy to open this up to others who have an answer to that. Unfortunately, I do not. I think it would be a prudent thing for them to do, but I don't know if they are or not. And last question that I see here, are you aware of studies evaluating potential impacts of marijuana smoke on air quality and human health? Thank you for asking that. That is my other hat that I wear with ACOG, which I did sort of enter parenthetically from the work with AAP and environmental health, because vaping was a very hot topic. So what I can say about this is that for pregnancy, so I'm going to speak about obstetric health principally here. We do actually have quite a bit of data now on the risks of cannabis exposure in pregnancy. And we have a systematic review of 30 studies. So a common refrain is, well, there's just not much that's known. We haven't studied it much. That's not exactly true. We have, like I said, at least one systematic review, and the risks associated with cannabis, and it's mostly smoking. Now it's true, we haven't teased out, edibles versus oils versus all that, but primarily these are inhaled cannabis that have THC in them. So not just the CBD oil. The risk is very close to smoking. So they have risks of low birth weight and preterm birth. And it is somewhat dose related, in that the risk is highest for women who smoke daily, as opposed to at least if it was less than twice a week, the risk was very low. If they smoked daily, the risk was high. There was also a synergistic effect with women who also had who smoked cigarettes. So they did account for that, and the risk held up separately, but it was even higher in a synergistic way. And it kind of makes some sense that inhaled smoke would have from marijuana would have similar risks to inhaled smoke from tobacco. But there's also a whole endocannabinoid system that is active during fetal development that's involved in axonal elongation. And so any cannabinoids or cannabinoids that are consumed during pregnancy act on this endocannabinoid system. And so the other outcomes we see besides just low birth weight are things like neurodevelopmental delay, which do have some pretty strong biological plausibility. So from the OB perspective, the counseling is there's no safe type, time, or amount of marijuana in pregnancy. The common kind of justification for it is that it helps with nausea, and if the doctors only knew what I knew, then they'd say it's okay to use this for nausea. And it's not only is it not recommended at all in pregnancy, we have other medications that are better for nausea. And there's actually kind of this paradoxical phenomenon called cannabinoid hyperemesis syndrome, where it actually probably revs up the process, we think, in the splanchnic nerve, so it's not clear how it works, but it increases their hyperemesis. So it makes the nausea and vomiting worse in pregnancy. It's called CHS, cannabinoid hyperemesis syndrome. So yes, that is kind of part and parcel with tobacco smoke, the risk with marijuana smoke. Okay, that's the last question that I see.
I think so. Well, thank you so much, Dr. Nicola. Regarding that one question before, regarding health insurance and climate risks, I'm not aware either of any of that being climate risk being taken into account. I will say that I've heard very preliminary information. I haven't studied it, that some health insurance companies are starting to take into account nature exposure and outdoor exposure, particularly as it relates to mental health. But and I have heard that this is quite common in Europe, and that in Europe, health insurance companies actually will include benefits based on nature exposure. But I don't have details about that. But actually, it's something that we may consider for a future topic. And I will say that, so much of what you're speaking about today resonates so much with me as a pediatrician, because so much of this also relates to my newborn patients. The risks that extend to pregnant women really extend particularly to newborns. And it has been something that I've been trying to shift in terms of my counseling for parents who deliver newborns. Last year was our hottest July in Virginia, and I saw a lot of newborn babies during that month. And I am now routinely saying it's really too hot for you to bring your newborn outside safely. You have to stay indoors in the air conditioning. I think that's something that should be incorporated into counseling for pregnant women as well during these times of extreme heat. Yeah. All right. Well, thank you again so much for that excellent presentation and for taking the time to educate our members today. And we look forward to following your work in the future and taking your advice into account and continuing our work as advocates for climate solutions in Virginia. Thanks so much. Thank you, everyone. Have a great day.